we had a debate earlier today, as some of you may know, and we discussed some of the things that have been discussed this evening. And
is that mic audible, or yep? We'll try this one.
Try this one. Okay. So one of the things I presented. So I'm presenting a case really for a precautionary approach at this time, based on reducing risk, and also the reality for me, and I was chatting to Alex about this a couple of weeks ago. I agonise over this thing because I'm like Alex. I was right at the front end back in the 80s, early 80s, involved in I guess the initiation of harm reduction as we knew it. I remember in Queensland, following Alex's intervention in Sydney around needle and syringe, we couldn't get government, the Joe Bjelke-Petersen government, to go with a needle and syringe exchange. But what we struck a deal was to have a trial of prescribed needles and syringes, and then to evaluate it at 6 months. There are 111 scripts across the whole of Queensland, and we went and talked to the Director General, at least Michael Bolton, the then Director did, and the government agreed that they would then punt for a change in the Drugs Misuse Act and allow needle and syringe. So it took a bit of work, and so I've, like Alex and Nico, I've travelled the globe preaching and supporting governments to implement harm reduction policies. It's really interesting that on this particular matter, I've reached a slightly different conclusion so far. And what I've read, I've probably got, I don't know, between 500 and 1,000 articles I've read on this subject. It's overwhelming, isn't it, what's coming out? And it seems to consume tobacco control advocates in terms of time to read and try and understand it. But there are three themes here at least that have been discussed. One is increasing accessibility of these products based on an assumption that they will reduce harm. The next one is making them accessible for therapeutic purposes to assist smoking cessation. Both important goals, if you like, both important public health and clinical outcomes. And then the final one is as a consumer product or commodity, if you like, that can be purchased for recreational, if you like, for pleasure purposes. And the problem is then looking at the literature and trying to work out what does it support in each of those three dimensions. Thank you, Richard. Health bodies themselves, both in Australia and internationally, are generally not jumping at supporting e-cigarettes. As Alex said, it's probably an unfriendly policy environment right now for these products. Next. And these are just a list of, on the left-hand side, Australian bodies, the Royal Colleges and so on, that right now are not supporting or are adopting, should I say, a precautionary harm prevention approach to the issue, the policy issue. Whereas on the right-hand side, we have the Royal Australian and New Zealand College of Psychiatrists standing out on its own as a medical body with DANA, the Drug and Alcohol Nurses Association. That's interesting in itself. Catherine?
I mean, if these are taken from the, as I assume they are, from one of the parliamentary inquiries,
yeah.
It's also interesting to note there was not a single doctor who wrote against e-cigarettes. Every single doctor who wrote a submission, and I think there were, 20 or so, all wrote positively.
Yeah.
So Catherine's comment, we should repeat. This was the submission to...
Well, this is either the upper house, but one of the federal...
the parliamentary submission.
Yes.
And all the doctors who wrote in, unlike these bodies, the individual doctors and experts wrote in favour of e-cigarettes.
That's right.
Yeah, okay. The next one, Richard. I'll take that as a comment. And the internationally, there's, of course, we know the WHO is taking a precautionary approach at this time, and a range of other, I don't know, can you read that list at the back, possibly? Yeah. Just by way of observation, next one. Now look, as someone working in addiction medicine, I also said today that, and I actually referenced Alex, that it's interesting that I've come to slightly different conclusions so far than many of my colleagues who, many of the comments that Alex has made tonight, of course I would support absolutely. I remember the definition and supported Alex in that definition way back. I thought that was the only logical definition. Of course we had police claiming that arresting people was achieving harm reduction by reducing the all sorts of illogical discussions that we fought strongly against, didn't we, Alex, and rebutted. But having read the articles I have, and Nico commented on this, look, I'm not a toxicologist or a cardiologist, but I'll come to this shortly, but I'm reading articles that are kind of putting a different perspective to the one that Colin has put around minimal cardiovascular risks by way of comparison. So in the generality, yes, that's true, but I'm still picking up on more recent papers that seem quite authentic and quite well written. But I don't have the skill set to analyse some of what they're saying. And so that puts me in a quandary. Like Nico, I have to be intellectually honest about this and say there'll be things I can critique reasonably and there are things that I can't. But the lessons learnt around drugs themselves, we've got a history, haven't we, of looking for medication solutions to human problems. And of course the amphetamine type stimulants, you see some of the advertising and promotion going back many decades in Australia, and then of course we've had opium in the 1800s and 1900s causing some problems in terms of the way the use of these products unfolded for everyday use as if they were innocuous things. Barbiturates, when I first came into the field, I was seeing a lot of deaths, and benzos were being prescribed increasingly because they were safer. They had a wide therapeutic index, and I was sold by that idea that benzos were harm reducing. But of course now you read the coroner's reports, the contribution, and it's not in isolation, of course, it's in combination with other depressant drugs, which is what we see, that the benzodiazepines are now looking pretty ordinary as a pharmaceutical, both in terms of therapeutic effectiveness when taken long term, but also in terms of risk. We're seeing Seroquel prescribed off-label, a range of other antipsychotics, and the antipsychotics are under challenge in the literature in terms of long-term outcomes, as are the antidepressants. Now the pain specialists are rethinking the role of strong opioids in persistent non-cancer pain prescribed long-term. Over-the-counter codeine combination analgesics containing codeine, and now they're going to be up scheduled because of the problems. The gabapentinoids are now causing significant problems, and we're getting concerned about those. And now the psychiatrists are talking about ketamine off-label because they're desperate to find a pharma solution to depression. And the latest is psilocybin. And so when you see these things in a career and watch them and experience them in your patients, and you start to think a little bit of caution in the chemical solution, as I say, to human problems. Is it the same or different to e-cigarettes? Let's proceed and see what I think. So smoking cessation. I won't dwell on these slides. Next one, Richard. This has already been presented tonight to you, but Becky Freeman, who's well regarded in the tobacco control field, presented the evidence that you saw tonight at the Oceania Tobacco Control Conference in Hobart several weeks ago, and she pointed out there are only really 2 systematic reviews subjected to meta-analysis worth considering in the international literature in relation to this question. And she said that we have to be very cautious about ends helping people to quit based on the evidence we have to date. Next one. So she said, putting her public health hat on, that there doesn't seem to be good evidence to show that they help a lot of people to quit, but they may help some people to quit. And regarding those who quit smoking combustible products and continue to vape, that should say, there are no definitive answers yet. She wasn't ruling it out, but she was saying, based on the evidence, we just don't know. Next, so just going on. So this is the Cochrane review that you've seen. Next one. The 2 studies that you've seen mentioned, and showing a benefit, but low quality evidence in those studies. Next one. And similarly, the other study, also very low quality, and in fact the evidence, the confidence intervals cross 1, so while this study found no statistically significant difference in the 6 months abstinence rates, Becky couldn't rule out that there is a clinically important difference. The studies just don't show that statistically. Next one. So she said there's evidence from 2 trials that e-cigarettes help smokers to quit in the long term, about 6 months, which is quite reasonable, compared to placebo. However, there are methodological problems, as I say, so the evidence is weak. Next one. And then there's this Dib et al. Study that was commissioned by the WHO, published last year, which we've seen already tonight presented and showing, in fact, a negative result. Next overall. Cohort studies, of course, themselves provide low-level evidence suggesting, however, a possible reduction in quit rates with ends compared to no ends. Next one. And these are some other systematic reviews. Glance, of course, is in the literature a lot, and people either follow him or don't agree with him. He's has his own perspective. He's been a leader in tobacco control internationally historically, but his study showed a 28% lower odds ratio of quitting, and so on. Next one. So Freeman reiterated at the conference, we don't have a bedrock of evidence upon which we can stand and make assertions. The evidence is weak and confidence in the results is incredibly low. They were her words, if I wrote them down correctly. Next one. So here's the thing where I look through these things at a slightly different lens. In my work as a doctor working in addiction medicine, over the years my focus has been increasingly around the population level interventions, public policy in particular, and I know certainly Alex has travelled the world and crossed straddled that fence, if you like, from clinical intervention to public policy. So there's a lot of similarity, and of course Nico's come from the WHO where policy is absolutely on his radar. But next slide, Richard. Recently, we've started doing using some dynamic simulation modelling to try and look at different policy interventions for alcohol, because governments just simply won't pay attention to the compelling evidence of what works to reduce alcohol consumption and alcohol-related harm. And Alex, I quote when I teach medical students, I put up Alex's MGA article of 1992 when he talked about when are we really going to act on the evidence that we've had for so long, and now we're another quarter of a century onwards from Alex's paper. So it's around price, access, and advertising, promotion, and sponsorship. They're the best buys, the WHO best buys, and governments won't go there. But we think if we can use this dynamic modelling, maybe we can just convince the state government at least to do something in Tasmania. These modelling approaches are being used also in tobacco control modelling, and so this is a paper presented by Frederick van der Deen at the Oceania conference 2 weeks ago, looking at tobacco endgame policies, because New Zealand has committed itself to a tobacco-free country New Zealand by 2025. Now, of course, they're not going to get there, but that's their aspiration, and they've got no plan to get there. But this group's decided they would look at the various endgame strategies, realising that the only way, theoretically, New Zealand could get there, and we've talked tonight already, and Nico's made a good comment about we were going to have a drug-free world by 2008, and that commitment was made at UNGAS in 1998 or 96, 98 I think. But with tobacco, it's a slightly different thing. I believe that the community in general doesn't support smoking now. There's a high 90% of smokers, some surveys up to show that so they want to quit, and the community in general, unlike alcohol, doesn't favour tobacco. So I think there is some chance that we could drive the rates down much lower. Now, I'll mention the hardening hypothesis in a minute, because that came up at Oceania as well. But in this dynamic studies, it was a sinking lid proposal where governments increasingly reduce the amount of tobacco that can be imported in New Zealand each year until you get to a zero import, and you could manufacture that according to one simulated modelling exercise to zero by 2025. The tobacco-free generation proposal that we've run with in the Parliament of Tasmania, and it's still sitting in the Parliament, is the next best in tobacco endgame. But you can see from the curves, you probably can't read there, it takes many years to get to even down to 5%. That line, we don't have a pointer, but the line you can see, that one is the Maori and the other's the non-Maori groups. It's 2030 before you, 20 2040, depending on which strategy, theoretically, before you get down to that 5% level, which in a Lancet editorial several years ago, they said that's the benchmark for a tobacco-free nation, ostensibly. Interesting, now they haven't used this modelling, but I spoke to Friedrich on a couple of days ago. They are looking at a range of other modelling exercises around tobacco control policies beyond endgame strategies to see what they come up with, like minimum smoking, legal smoking age, and ends as a smoking cessation. And of course, you plug in various estimates of best case, worst case, sensitivity analysis, and it stands or falls on the basis of what you plug in and the calculation that you do. But it's an interesting exercise to try and understand what ifs and to influence policy, if you like. Next one. So from my question, the issue about what these studies suggest, though, and in talking to Frederick, treatment, as in alcohol, if you do the simulation around alcohol, treatment has very little effect on the curves. If you increase your, boost your, you double your brief interventions, let's say, and you look at emergency department presentations, it's very hard to see the difference in the curve. Whereas the big policy initiatives, price, access, advertising and promotion by way of example, and in tobacco, also social marketing. You know, one of the reasons that was proposed at Oceania for the stalling of the reduction in Australia was that we're doing very poorly in terms of the TARPs, the investment in social marketing, save Tasmania, that reached a benchmark that's been set. Whether that's true or not, I can't say, but that was what was suggested at the conference. Now, so my concern is, although treatment, any civil society should rightly offer the best available treatment and make it as accessible as possible and affordable. When we, for commercial profit, sell unhealthy commodities that do great harm and that indeed may kill 2 out of 3 citizens who use them exactly as industry intends them to be used, which is the common saying. But there's a different question between compassion and doing the right thing and offering treatment and the population impacts and what makes the difference. So it's unclear to me, and Nico and I talked about this last week, he thinks that the data influencing the alcohol modelling is insufficient, and I agree with him, that it probably is more effective than the modelling shows, but we just don't have that data at the moment. And we know ICD coding for alcohol in our hospitals is more than order of magnitude out of kilter of the real figures for presentation. So our data is terrible, and rubbish in, rubbish out in any modelling exercise. But I asked the question, have we got public policy right? Well, we've done pretty well in tobacco control compared to alcohol historically, but what I see potentially happening now is e-cigarettes maybe, and I'll show you the next slides, maybe the e-cigarette industry plus the tobacco industry where it's integrating is trying to change the face of this and undo potentially the public policy reforms that arguably have achieved so much. Next one. Now, the hardening hypothesis was discussed at Oceania, but before that, Moore, McKee and Daub commented on it. They questioned the veracity of the hypothesis, and they say that it's not supported by empirical evidence. Next one. But Melanie Wakefield, who's of course well regarded once again in the tobacco control field, presented a paper at Oceania saying they put the question to the test in Victoria, and based on, but mind you, a lot of this research is based on self-report, whether it's in support of ends or whether it's counter to the effectiveness ends or other tobacco control measures. It's self-report, and then of course a lot of the stuff is cross-sectional, as Collins mentioned. And it's also difficult to interpret it with confidence. But anyway, given the limitations of this research, Wakefield tested 7 different outcomes that they would expect if the hardening hypothesis was true. And for each of those 7 tests, they got a negative result, if you like, a relative risk below 1. So she said, rather than the evidence supporting hardening, that is, as the prevalence of smoking goes down, you get a more resistant group who won't or can't stop, they found, if anything, an evidence for a softening. One study, significant methodological limitations. But there you go. That's the literature I'm reading. On one hand, we have this. On the other hand, we have something quite different. Nico's presented a different approach tonight than we've heard from Colin on some matters. I was in Poland in 2012. I was struck, and I remember saying to my wife, you know, repeatedly, young people smoke vaping, and the behaviours I observed, I came back and said, you watch these products go amongst youth. It was just something, you know, from my experience that I just saw alarm bells. And that has flavoured my caution, I guess, because addiction, nicotine dependence in youth, to me, is not a small deal. Next one.
About 6 minutes.
Okay, thank you. Aggressive marketing tactics worry me. I'm sure they worry you. Perhaps they worry me more than most. But there's certainly the e-cigarette market is now resembling the tobacco market going back in the 60s onwards. Next slide, thanks. Next slide. So we're seeing, as we've heard already, and you've seen from Nico, celebrities, sex, glamour, adventure, rebelliousness, youth and beauty associated with the promotion of these products. And of course that's at odds with some of the industry's campaigns suggesting they're for therapeutic purposes, although as Nico showed, unashamedly some of the ends producers are saying, why stop, why quit? Blue, you know, we've got a new product for you that is just very attractive. Why don't you switch to our product? Next slide. So to me, this is a brazen action from industry to seduce young people and not so young people to use these products, and I fail to see how that's consistent with a therapeutic intent. Is it consistent with a harm reduction intent? I'm not even sure about that either. Next one. Here we see, as Nico showed, why quit? So that's clearly contrary to the therapeutic claims. Or next one. And then here we have take back freedom. Well, in my experience working in addiction medicine, addiction provides anything but freedom. In fact, it axiomatically snatches freedom from the individual, and with loss of control and all of the features of dependence that we see in smokers. I mean, it's no small matter seeing the impacts on the repeated withdrawal that smokers go through the day, and having to excuse themselves and go outside and smoke, and all of the other behaviours that we see, and the imposts on people's lives. I think we should be outraged about this, but I don't see the outrage.
We're outraged, and there's no question that sort of advertising is going to happen in this country.
Yes.
And I think it shouldn't happen anywhere. That's what we would all like to see.
Yeah. So that's part of it. We're saying if we're going to have regulation, I just want to make the point, this has got to be in there. This has got to be in there. Next one. And if it doesn't sell on merit, once again, it's the celebrities. So remember, the more doctors smoke Camels than in any other brand. There's a resemblance here, isn't there, to tobacco. Go, next one. And of course the attractive packaging, next line. The 8,000 flavours, to name a few. Now the industry claims that this makes them more attractive. It's a good thing to have all these options, all these choices. I say, not from an addiction perspective if this is for therapeutic purposes. If it's a commercial product, but then there's the issue of risk associated with these products as they currently, if they're combusted, as we say, there's various models of devices, and I think if we're going to move forward, as Nico said, we're going to have to think about delivery systems that don't either you remove the flavourants through regulation, or you remove the risk associated with inhaling flavourants when we just simply don't have the knowledge. Alex, yes.
Can I ask you, Adrian, in a professional capacity, not personal, how do you feel about flavoured condoms?
The question was how Adrian feels about flavoured condoms.
I could give an answer to that, Alex, that I might. I don't think we inhale.
Would you want people to use condoms?
I don't think the analogy is quite there because of the risk, Alex. I get what you're saying. It's make the product attractive so people use it. That's the argument. But the problem is, inhaled deep into the lungs, we don't know. We simply don't know what the risks might be. Next one. Yeah. So next one. Clearly, if the ends is to survive, it's going to survive if it's for commercial purposes, but if it's for therapeutic purposes, then there's a question around, does the industry see itself as coming to an end in 20 years or 30 years when we're done and dusted with smoking? I don't think so. Next one. Youth uptake, next one. Human steam trains, it's part of the culture, isn't it? I look at that and it's a turn off, but clearly for young people it's a turn on, like the colours, the flavours, the names, the branding and so on. Next one. Nicotine is hardly harmless, next slide. So once again, everyone in the room here knows what I'm talking about here, that, and I've mentioned this already, addiction does oh, sorry, Alex, thank you. Addiction does, it does reduce life chances, life opportunities, and has an impact on choice and human agency. And part of why I'm where I'm now, as I'm sure you are, is that as a younger doctor, I felt emotionally really hit me that people's lives, how they were changed. You know, I started off with heroin injecting, treating heroin injectors with methadone, and saw how they improved so rapidly with methadone, and it kind of got me hooked on this field. And I don't like to see us wittingly, for commercial vested interests, taking advantage of people and addicting them, or saying that that's no small matter. Next. But of course people can and do stop even when they are addicted. I don't want to send the message that people can't stop, and in fact we talked a lot about that today. Next one. And of course stress. There's the arguments that smoking, and this is the problem in mental health units over many, many decades, that doctors and nurses working in these units thought that tobacco products were therapeutic because it eased stress and so on. And I thought the Smoke and Mirrors report of the New South Wales Cancer Council 2008 nicely sort of undone that idea. Next one. Once again, coming to this point now, a reason that I'm still sitting in the precautionary field. I've said to you, I've read many papers, including many papers talking about the cardiovascular respiratory effects, some minor, as Colin has presented, but some of the more recent papers showing that the risks may be greater, or certainly close to tobacco products. I don't have the expertise really to evaluate them properly. I was going to put some of them up tonight. A, I realised I didn't have time. And B, I thought, well, you'll ask me questions and I won't reasonably be able to answer some of the detail because it isn't my expertise. Safe to say, once again, I'm seeing so much. It's a messy, confused field. It really is. Next one. I think it's quite unusual. But by the way, the 95% claim, I get it why they got to that conclusion. Colin mentioned, you know, for many of the comparisons, the percentages, you know, 1 or 2% or maybe thereabouts. The problem is they haven't evaluated some of the newer evidence around, for example, the impacts on vascular, you know, stiffness, so the platelet functions, and some of the effects on cardiovascular and even cancer risks. We heard tonight Colin say, was today, that the cancer risks were very low. But some of the papers I'm reading are questioning that as well. So, but let's imagine ends came first and tobacco products were only introduced in the last 15 years, and we're doing the comparison. We'd be comparing what we know, and we would have now a very good understanding of the 8,000 flavourants and the effects of propylene glycol and glycerine when they're inhaled, and the metals and so on from the various devices. So we'd be comparing tobacco products with what we know about ends. And it might be, for a while, we might say, well, the balance might look in favour of tobacco. It might not, but it might, until more evidence unfolded, and then the calculus would change. Just to make the point about the 95%, how you calculate these things. If you don't know what you don't know, and we haven't done the toxicology on these flavourants, and as I say, some of the studies coming out on fine and ultrafine particles affecting cardiovascular health, to me look a bit worrisome, and I think they deserve a bit more careful attention. Well, I'm out of time, aren't I?
Thank you.
Keep going with, I'll pass over that. Product regulation, if we were going to regulate it, that next one. I can think of at least 22 things. If it was going to be a commercial product, we'd think of some of the things around that we do or think about with alcohol. So it's no small matter, regulation. It's not just a matter of regulating one or two things. We need to think more broadly if we're going to go forward. Next one. Harm reduction. This paper, I don't actually agree with everything in this paper. I put it up there for you. I think Alex, nailed it tonight in terms of his definition, but the definition Michael Moore and et al. Are running on is that harm minimisation is the three pillars that we've traditionally run on with the National Drug Strategy. Although I do agree with access being, for any commercial product, it must be considered. But a different kind of argument. Next one. However, so that's what they presented. Next one, I'll slip over that. I just make the point, the comparisons that have been made tonight and elsewhere around with needle and syringe and methadone and so on, not quite the same, because they're not marketed to attract people with all the, who are addicted with all the hype that we're seeing with e-cigarettes. And I don't think we'd ever, we wouldn't want to do that. So, I mean, I think they're not quite the same. I'm not comfortable with that comparison. Next one. So in summary, I'm based on what I've read, I'm not persuaded. It's a messy, complicated literature. It's a huge literature. Very varying analysis and interpretations of the same papers. We heard comments tonight on Levy today, and earlier today we heard Matthew Peters had quite a different slant on the Levy paper, didn't he, Colin? And he was quite strong about that. I'm concerned about the promotion of ENDS as yet another affect modulating substance as a commercial product in itself. And I'm concerned about the behaviour industry. I'm concerned about the downplaying of nicotine addiction if it increases across the population into the future, if it's a commercial product. And as a doctor who's seen it so many times, it's safe, and then it's not. I'm not ready to accept the arguments that these things are safe in the long run. Thank you, ladies and gentlemen.
Thank you, Adrian. There's good reason to allow this one to go 10 or 12 minutes over time. I think we've got time for maybe just one or two questions, and then, one from Catherine.
Catherine?
Well, a comment, which is, I guess, a lot of us in this room have been working in the substance use field for 25 years, and during that time we've seen the population rate of smoking decrease significantly, down to around that 15-16%. However, the smoking rates of our patients are still around at least 80, if not 90% plus. Yeah. So I think we have a group of patients who are, I guess all of us have got patients who are now in that older age group who are dying of their respiratory disease. And we're not addressing their tobacco use is just a disaster. This stuff is happening around the world. We can't put blinkers on and pretend it isn't happening. People can get hold of the stuff if they want to, and I think we need to address the advertising, but I think we need to get on with something that's realistic and doable.
Catherine, I think two things. We ourselves are at fault around not addressing smoking cessation until recent times, and Alex has spoken strongly about that, and I certainly do, and there's a study coming out now showing that people do better in general if you treat co-occurring dependencies rather than, adopt one at a time. That sounds reasonable. We were with treating people unkindly with kindness.
You'll manage your cannabis use and you'll go from smoking 10 cigarettes a day to 40.
Okay, we're going to have to close up. That was a really good comment, Catherine, and really great presentation, nice answer. I think it's time to thank the speakers who've come so far in some instances and given us such a fantastic interview.